Good evening, respected delegates. We welcome you on behalf of Ahmedabad Obstetrics and Gynaecological Society for first hybrid CME, along with MCure as our sponsor and partner. We would like to have introduction of Dr. Jignesh Deliwala, sir. Can we have CV slide, please? Sir is practicing gynec at Ahmedabad since last 18 years. He is President AOGS for the current year. He has been past Honorary Secretary of AOGS and past Joint Secretary of AICOG 2017. And he has a special interest in high-risk pregnancy and fetal medicine. We welcome you, sir, to deliver the welcome address for this particular first hybrid CM of AOGS. Thank you.
Thank you, Dr. Munjal. And I extend a warm regards and gratitude on behalf of AOGS to all my fellow members, respected teachers, and dear friends across the India who are in online mode. So today we are going to witness one of the best speakers of Foxy, or I would say it's India, that is Dr. C.B. Nagori and Dr. P.C. Mahapatra. And along with that, we have one interactive session with Dr. Mukund from MCure, who is going to deliberate the molecule, the importance of the dihydrogesterone. And without wasting much of time, I would request Dr. Munjal to proceed for this CME. Thank you.
Thank you so much, sir. We would like to have CV slide of our coordinator, Dr. Hetal Patolia, madam. Can we have the CV slide, please? She is practicing gynecologist at Ahmedabad, recipient of 5 gold medals for academic excellence, forever student studying hospital management to clinical research to philosophy, and ardent social worker working with various NGOs for women's health, and specifically dedicated for PCOS and adolescent PCOS. We welcome you, ma'am. Thank you so much for coordinating today's hybrid CME. Thank you.
Thank you for the kind words, Dr. Munjal. A very warm welcome to all the delegates who are present here and all those who have joined us online. Today is a very special day. One, because we are having a physical CME after a very, very long time, and seeing each other's faces and meeting is such a happy occasion. Secondly, we are just a night away from the 75th celebration of our Independence Day. So a great evening today. Now, hearing the name of the speakers, I think we all just can't wait to begin. I would like to now invite the chairpersons for today's session. The chairpersons are 2 luminaries from the AOGS Society. First is Dr. Hemant sir. Dr. Hemant sir is the national coordinator of FOGSI. He has been the honorary treasurer of SOGOG, past president of AOGS for the year 2017-18, organizing secretary of AICOG 2017. He is the trustee of Ahmedabad World Heritage City Trust, and recently he has been appointed the media cell convener of BJP Gujarat. Welcome, sir. Honored to have you with us. Our second chairperson today is Dr. Kamini, madam. Dr. Kamini is the CEO of Vani IVF Center with special interest in genetics and stem cell therapy in infertility. She is held various awards whenever she holds post. So she had the Best Secretary Award at MMM. She's also been an award winner in the Breast Committee of FOGSI, and she's very active in working for the Adolescent Health Committee of FOGSI. She's been a member of various professional bodies and held office as honorary secretary, and she is at present the president-elect of AOGS. She also has numerous publications to her credit. Madam will be joining us shortly. So I hand over to the chairpersons to begin today's session.
Good evening, respected seniors and dear colleagues. It has been the occasion of great elation and joy for all of us that after 1.5 years, we are in the mode of organizing a physical conference as well as our webinar together, that is a hybrid CME today for our esteemed members. And what can be a more joy or a more respect or a rather more sense of satisfaction for AOGS than we are having our own teacher, rather I would say teacher of teachers, Dr. C.B. Nagori, inaugurating the year as well as this CME. Anybody who has done his PG residency in Ahmedabad, either at civil hospital or at VS hospital in their 80s and 90s, they all knew the most lovable teacher of that time, Dr. C.B. Nagori. And now there are hundreds and thousands of students. We welcome Dr. P.C. Mahapatra sir for today's CME. And fortunately, he is physically present over at Ahmedabad for this CME. So that is also a great sense of satisfaction and joy. And before I introduce our teacher, Dr. C.B. Nagori, let us start our auspicious occasion with the lamp lightening. If it is ready, then we can have the prayers for the God Almighty, so that our coming year should go without any hiccups or the roadblocks of the third wave of COVID. So I would request Dr. P.C. Mahapatra sir, Dr. C.B. Nagori sir, Dr. Jignesh Diliwala, the AOGS President, Dr. Munjal Pandya, our Honorary Secretary, Dr. Hetal, our coordinator for today's CME, Kamini Ben, is she here? Okay. And Dr. Snehal Kale, our Honorary Treasurer. I would also request Snehal to recite some hymns along with the lamp lightening. So we are proceeding for the first lecture of today's CME, and just to complete the formalities, I have the pleasure of introducing Dr. C.B. Nagori sir. He is the director of Dr. Nagori's Institute for Infertility and IVF. He has been awarded the Best Paper Award in the World Congress of ISUOG in 2008 at Chicago. He has the privilege of having the first stem cell pregnancy in India. He has published several papers in index journals. The first ever Center of Excellence for Ian Dunal School of Ultrasound has been Dr. Nagori's Institute at Ahmedabad. He holds regular trainings in infertility, IVF, and ultrasound. He has contributed a lot in several academic books, and he has authored a very popular book for all the novices who are starting their practices. And a day-to-day clinical practice is always becoming fertile and flourished if you have this handbook of infertility and ultrasound with every practicing gynecologist. I have the proud and privilege on behalf of AOGS to welcome Dr. C.B. Nagori for today's first lecture on LPD. Thank you, sir.
At the outset, I am very thankful to Ahmedabad OBGY Society, all the organizers, Deliwala, Munjal, and all the organizers. Thankful to Hital as well as the chairpersons Hemant and Kamini. With due respect to PC sir, I am starting my talk. Whenever we talk about a luteal phase support, the two questions come in our mind. One is when to use the luteal support, and second is what to use for the luteal support. Let us elaborate on both the things. I think Deliwala has already told me that the topic is for ART, but few aspects of IUI also is to be covered, and that's why I'm adding few slides to my talk. Now, when to use a luteal support? Let us consider one by one, and that is the natural cycle. Whenever there is a natural cycle, there is always an endogenous surge, and this LH surge is sufficient to produce the progesterone receptors, and that is why the routine use of the progesterone is not justified in a natural cycle. Many people start from day 14 onwards or 15 onwards the progesterone in a natural cycle, which has got no role. Then why LPD occurs in a non-ART cycle? In a non-ART cycle, there is an abnormal follicular genesis, and that is why E2 level is less. That's why positive feedback mechanism will be less. And that's why the corpus luteum will be very unhealthy, and there will be the progesterone deficiency. So abnormal follicle is responsible for a luteal phase support. Luteal phase defect. So at this stage, you should not go on giving progesterone to the patient. Instead of that, you should try to improve the quality of the follicle. If you improve the quality of the follicle, the luteal phase is taken care of. These are all the conditions where you always find a luteal phase defect. And here what you have to do, you have to just improve the quality of the follicle by either oral ovulagens or by the gonadotrophin. Then you will get a good quality of the follicle and the luteal phase will be okay. Now, many times we start clomiphene citrate for infertility. Now, clomiphene acts on the hypothalamus, increases FSH and LH both. Now, this increase in LH is sufficient to take care of the luteal phase, and that's why whenever you are giving clomiphene citrate to any patient, and even if you are doing an IUI, then the luteal support is not required. So unnecessary, you can avoid so many drugs to the patient, particularly the clomiphene LH takes care of everything. Now, luteal phase support in a gonadotrophin cycle. Gonadotrophin we use for IUI cycle as well as for an IVF cycle. And when we use gonadotrophin, there are multiple follicles, and multiple follicles causes high level of E2. And this high level of E2 decreases an LH level. So whenever you use gonadotrophin, the LH level is decreased in the later follicular phase as well as in the luteal phase. And this low LH is responsible for a luteal phase defect, and that's why you should always give a luteal phase support whenever you are using the gonadotrophin. Apart from that, you are adding agonist or antagonist or HCG trigger, and all these conditions require a luteal phase support. So all stimulated cycles with the gonadotrophin always require a luteal phase support. Now we always give HCG when the follicle is mature, when you want to do an IUI. And at that time, when you give a surrogate LH, HCG is a surrogate LH, and when you give an LH from outside, the endogenous LH level decreases. Now, this decrease in endogenous LH can cause the luteal phase defect. But whenever you are giving 5,000 to 10,000 units of HCG, then the biological half-life is up to 5 days. And that's why up to 5 days, there is no need of any support to be given. Now from day 5 onwards, the LH level decreases because of this surrogate LH. And that's why the luteal phase defect starts from day 5. Now the embryo, means when the pregnancy occurs, it starts secreting beta HCG from day 8. And that is why between day 5 and day 8, there is always a luteal phase defect, and because of the decrease in the LH. And if you don't supply progesterone to these patients, then either the chemical pregnancy or the implantation may not be proper, and the luteal phase defect is always there in this group of the patient. And that is why whenever you give HCG trigger, even it is an IUI cycle or an IVF cycle, whenever you give HCG trigger, then the luteal support is always to be given before the 5 days. Either normally we always start from the day, second day of an IUI, or in an IVF after the home pickup we start. So this is the luteal gap you must remember, and it should be always given the support. GnRH agonist and luteal support. Almost GnRH agonist has gone out as far as the IVF cycles are concerned. Nobody does the down regulation with GnRH analog. Majority are doing an antagonist cycle. But those beginners who are doing an batch IVF, or when you are calling somebody from outside for a pickup and transfer, then at that time you will collect all the patients and you will start the batch IVF. And in this batch IVF, you always use GnRH agonist for down regulation. And this down regulation decreases an LH level so that you require a judicious support, that is the luteal phase support is required to this patient. So whenever you use GnRH agonist for down regulation, luteal phase support is always required. Now majority cycles are the antagonist cycle, and when the antagonist came in the market, people used to believe that the antagonists don't require a luteal support, and that's why lots of pregnancies were wasted when the antagonist came in the market. People did not give a luteal phase support, and lots of pregnancies were wasted at that time. But now people realize that antagonist also decreases an LH level, that effect continues in the luteal phase also, and that is why there is always a luteal phase defect. So all antagonist cycle must be given the luteal phase support to all the patients. Now in an IVF today, almost people are going for the freezing cycle, or whenever there are multiple follicles on both the sides, then the fear of OHSS is always there. And that is why we always give an agonist trigger. Now, what is the difference between the agonist trigger and the HCG trigger, or a natural cycle? When you see a natural cycle, when the LH surge occurs, then it has got three limbs. One is an ascending limb, second is a transverse limb, and third is a descending limb. That is 14, 20, and 20. So it is total 54 hours is an LH surge. But if you give an agonist trigger for the rupture of the follicle or for doing an ovum pickup, then at that time, ascending limb is 4 hours, descending limb is 20 hours. So it is only for 24 hours. Now, what is the difference? The LH surge, which is for 24 hours, can complete the meiosis, but cannot rupture the follicle. While if it's in a normal cycle, it is 54 hours. So here the meiosis is present. And that is why you can do an ovum pickup, the quality of an ova will be very good. But because the LH level is for a very short duration, it may not help for the luteal phase. And that is why whenever you give an agonist trigger, the luteal support is always required. If you don't give properly the luteal phase support, then the pregnancy will not occur. So the most common is for freeze all cases. In all PCO patients, we do an agonist trigger, we freeze all the follicles, and then we transfer in the next cycle. Now, whenever there is a luteal phase support, it is to be given in an agonist cycle, particularly a fresh transfer. See, normally we always freeze all the embryos, but otherwise when you want to do a fresh transfer to these patients, then being an agonist trigger, the LH surge is low, luteal phase defect is going to occur, you can do 4 things. One thing is intensive exogenous E2 and progesterone support. You can give a dual trigger. You can give HCG at the time of retrieval. You can give low dose of HCG in the luteal phase. And 5th is a recombinant LH. Now let us consider one by one. That you give exogenous E2 and progesterone to this patient, 25 to 50 milligram intramuscularly. Formerly we used to give, but nowadays aqueous is available. So we give 25 to 50 milligram of an aqueous progesterone, then 800 milligram of the vaginal progesterone to be given, or 2 to 8 milligram of estradiol valeriate is given to this patient. Adjust the dose so that you can get E2 between 200 picogram per ml and progesterone for about 20 nanogram per ml. If you maintain this by giving estrogen and progesterone from outside, you can do a fresh transfer to this patient. Now, what is a dual trigger? I told you that whenever the LH surge occurs, LH surge is only for 24 hours in an agonist trigger. Now, in some of the cases where you have already given oral contraceptive pills for 2 to 3 months or 4 months, and then you have started your stimulation protocol, or some of the patients of endometriosis, where you may not get a sufficient LH surge, and that's why when you start doing a pickup, you get an empty follicle syndrome. You don't get a single follicle. You are surprised that I've already done a pickup in one ovary and I have not got a single follicle. These are the cases where the LH surge does not occur in spite of giving a GnRH agonist trigger. So on a safer side, if you want to do a fresh transfer, I told you for completion of meiosis only 500 to 1000 units of HCG is required. So you add 500 units to 1,000 international unit of HCG to this patient along with an agonist trigger, the empty follicle will not occur due to lack of LH. And here it has been found that the pregnancy rate is up to 53% pregnancy rate has been found with the fresh transfer to this patient. So it works as a backup of a GnRH agonist failure, and that is why the dual trigger is preferred those who want to go for a fresh transfer when you want to give an GnRH agonist as a trigger. Now, this is the best Professor Umedian's regime that when the E2 level is more than 4,000 or when there are more than 25 follicles of 11 millimeter size, then we do a pickup, freeze all the embryos and transfer in the next cycle. But suppose you want to do a fresh transfer, then the E2 level should be less than 4,000, or if you have got a good ultrasound machine, then you can have 11 millimeter size of the follicle, the number of follicles should be less than 25. If they are less than 25, then at the time of pickup, you can give 1500 units of HCG to this patient, and that will rescue the luteal phase. Second dose of HCG should not be given to this patient, otherwise it can end in an OHSS. But when the number of follicles are less than 25 of 11 millimeter size, that you can give HCG 1500 units to this patient at the time of pickup. Even there are multiple follicles, you have done an IUI, and there are 3-4 follicles on both the sides. It's always better to give 1500 units of HCG at that time, and that will not cause the luteal phase defect. You can give a luteal support along with it, but the luteal phase will be normal and the pregnancy rate will be very good. Recombinant LH is very expensive and it's not possible at all to give recombinant LH. Now, why we go for an FET cycle? FET cycle is for prevention of an OHSS. We want to do for PGS or PGD is required, particularly when progesterone level is more than 1.5 nanogram. This is very common because the high doses of FSH are responsible for progesterone rise before your HCG. And these are the cases where you will freeze all the embryos because that is detrimental as far as the implantation is concerned. Then the fluid in the cavity, single embryo transfer, and the patient or clinician choice, we always do an FET cycle to this patient. Now in FET cycle, either you can go for a natural cycle, you can go for modified natural cycle, or you can go for an artificial cycle. In a natural cycle, we rely on an urinary kit and then we decide, but most of the time your the timing may not be matched. And that is why people say that the luteal support is not required, but there are a lot of papers which tell that then because the endometrium is out of phase, and that is why the luteal support is always required when you are transferring in a natural cycle also. Modified natural cycle, develop a follicle, rupture it with an HCG, and then on day 7 you transfer. Now here the progesterone support is not required in majority of the papers because the corpus luteum is present. Results of natural cycle and modified natural cycle, they are the same, but almost majority of the cases are going for artificial cycle. Artificial cycle, you give estradiol valeric 2 milligram 3 to 4 times a day till you get an 8 millimeter endometrium. Now it is very important that you should give minimum requirement of estradiol valeric is 12 days because the progesterone receptors don't develop unless you give it for 12 days. And second thing is, when you give a progesterone, that is the day 0. When you start a progesterone, it is day 0. And when you want to do a blastocyst transfer, day 1, 2, 3, 4, and 5, we transfer. So, unless you get a vascularity in a zone 3 or zone 4, after giving estradiol valeric for 12 days, 13 days, 15 days, 17 days, please don't start the progesterone. If you want to get an excellent result, freezing cycle, the results are excellent. You can reach up to almost 80% results can be achieved by frozen transfers, provided you see the endometrium which has got a vascularity in zone 3 and 4, and then you start a progesterone, and then if you transfer, the results are excellent. Progesterone given 3 to 5 days according to the day. What is important is that maximum 28 days. Don't go on continuing the estradiol valeric for number of days and then do try to get an endometrium. Maximum number of days are only 28. And whenever the pregnancy occurs, the corpus luteum is absent, and that's why you are supposed to give estrogen and the progesterone almost for 12 weeks. So 10 to 12 weeks is the minimum requirement on these patients. So natural cycle, modified natural cycle and artificial cycle have the same results. And what is the beauty of this? I would like to tell you everybody that we go on prescribing lots of drugs to the patient in the luteal phase. But what this frozen cycle has taught us, that only estrogen and progesterone, only these two things, all other substances like androgen, peptides and everything which is secreted from the ovary are harmful, and these are not good for uterine receptivity. That is why don't go on adding the drugs to the patient as far as the luteal phase is concerned. It's only the estrogen and progesterone that can give you the excellent result. Now, in a frozen cycle, it was found out that when you give a progesterone, then in many patients, the level of progesterone is less than 9.2 nanogram per ml. And these are the patients who will abort. And that is why the 2018 study that came in the market, that you should give intramuscular progesterone on an alternate day. And then the second paper came that you should give 25 to 50 milligram of an aqueous progesterone every day along with the vaginal progesterone. Then you get an excellent results with the frozen transfers. Now, the day previous to transfer, this is 2021 paper, recent paper which has come up. The day before the transfer, you get the progesterone level done. And if it is less than 10.6, you give subcutaneous progesterone in a higher dose, progesterone level will be maintained and the pregnancy level will be very good. There are a lot of patients, I think this is another paper which has come in 21, that 8.8 nanogram per ml, if it is the progesterone level, then if you don't supply the proper progesterone, then the implantation will not occur properly. That is why the level of progesterone is extremely important before you transfer your embryos. Now, all of you know, this is also a very good thing. All of us have learned that the serum progesterone more than 3 nanogram per ml indicates that the ovulation has occurred. But for an implantation, the level of 8 to 18 nanogram per ml is required for the gene expression. So only 3 or 4 milligram, that will document ovulation, but the pregnancy will not occur in that case. If you want to even suspect whether this patient has conceived or it is not conceived, the minimum required progesterone level will be between 8 to 18 nanogram per ml, because the gene expression is only with this level, otherwise the gene expression does not occur. Now, the few recent papers in 21 which has come, that the frozen transfer has got only one disadvantage, and that is the high risk of hypertensive disorders of pregnancy. There are few papers which are coming up that if you do a frozen transfer, then the obstetric carrier, the hypertensive diseases are very common. And the reason is that the corpus luteum is essential for maternal cardiovascular adaptation in early pregnancy. So corpus luteum has a tremendous role to play in a later pregnancy. This paper has indicated that prevents the cardiovascular diseases in the later pregnancy if the corpus luteum is present. And that is why now there is a lot of debate whether you should go for an artificial cycle or whether you should transfer in a modifier. I think the time will tell us. After a few years, the more and more paper will come. But the recent paper tells that the hypertensive disorders are only because of this. Agonist, we don't use it. So this is what I have discussed, that in which conditions you require a luteal phase support. Now, what to use for a luteal phase support? You have got progesterone, HCG, GnRH agonist, and additional E2. I already told you that the progesterone is required for a luteal gap, day 5 to day 8 progesterone deficiency, particularly when you give HCG to this patient. And micronized natural progesterone is most commonly used vaginal progesterone for this purpose. Now, the progesterone that is available to you is intramuscular, subcutaneous, transdermal, oral, and vaginal progesterone. Intramuscular progesterone was very popular before. I think there were a lot of papers which has given an excellent pregnancy rate, but it's severe painful. I think if I tell you in inverted commas the words of Peter Brisden, that first injection should be taken by gynecologist and the second should be started to the patient, then you realize how much painful it is. And that's why it is never popular. And because the subcutaneous injections are nowadays available, you can go for subcutaneous injections which are extremely less painful, I would say. And 25 milligram, and body weight shows the negative correlation. That's why those who are obese patient where the BMI is more, these are the patients where you should give 50 milligram instead of 25 milligram should be given to this patient. Transdermal progesterone not popular because the dose is very high and it is detoxified by 5-alpha reductase. The vaginal progesterone most popular It is the first uterine pass effect that all of you know that it straightway goes to the uterus. And second is the counter current mechanism. Now, what is the counter current mechanism? The drug which is absorbed from upper third of the vagina goes to the vein, and from a vein it goes to the artery. This is possible only in the upper third of the vagina. Nowhere this counter current mechanism is possible. And from artery it goes to the uterus. So it has not to go to a general circulation. It can straightway go from vaginal application. It can go to the uterus. And that is why the serum levels are found to be very low, while the uterine levels are very high. And that is why you should always do a serum level of the progesterone has to be established according to the which progesterone you are giving. If you are giving vaginal progesterone, if you are giving intramuscular progesterone, subcutaneous progesterone, accordingly the level will be different. And the paper should come forward that which is an ideal level for which condition. Then and then you can tell whether the luteal phase defect can occur or cannot occur to this patient. Now there is a reason one Japanese paper has come that 1200 milligram is an ideal dose. And I would agree to this because from the very beginning, I am using only 1200 milligram as a luteal support. And so if you use 1200 milligram, 400 milligram 3 times a day is an excellent luteal support for the patient. Progesterone gel is also excellent and once a day application. Higher the age than we always applied twice. That is 1 BD, the gel is applied to the patient, but that has also got a very good results. Oral progesterones are ineffective in inducing the in-phase endometrium. That was long back said by Professor Paul Devereaux as well as the Fatemi's paper. And that's why the oral progesterones are not popular. But now you are getting more than 25 companies have come forward with the progesterone SR tablet, sustained release tablet. This sustained release tablet, I'm not against this, but I have not used this. And what I would like to tell you that it is only available in India. It's not available outside. You don't get a single paper in fertility sterility. You don't get a single paper in the human reproduction also. And I have not seen a single clinic who is using only SR tablet as a luteal support. So it is just given along with the drug, whatever you are giving. But this requires judicious trial. But unfortunately, every few months, one more company comes with an SR tablet. So the market is very good. Because it is once a day, people are using it. Now the dihydrogesterone, formerly it was available with only Abbott now, but you can see that now about 5 to 7 companies are coming with the dihydrogesterone. What I would like to emphasize is that this is also not properly evaluated drug. If you see the paper, older papers, then up to 60 years it was with an Abbott company. Up to 60 years, but the papers on Lotus trials have come only recently. In last 3-4 years only the trials have come. So this should be more and more trials should come for the efficacy. This dihydrogesterone was compared in a Lotus trial with 600 milligram of the progesterone. Nowadays cyclogest pessary was given with 800 milligram, and recently people are giving 1200 milligram along with the subcutaneous injection. So now the more and more papers should come to compare the efficacy of the dihydrogesterone along with the vaginal progesterone. Then you can tell that whether the efficacy of both the drug is same or not. Now, very important paper which has come in 21 that the use of oral progesterone is not recommended in a woman with threatened miscarriage in the first trimester. This is a good paper to be read, 2021 paper, that we go on bombarding the progesterone to a patient if the patient bleeds or when you are afraid of an abortion. And it has been proved in this paper, very well paper in human reproduction, that the progesterone does not work at this stage. Progesterone resistance, particularly endometriosis and PCO, these are the papers where the implantation does not occur because of the progesterone resistance. And that is why you should remove the progesterone resistance first, otherwise the implantation will not occur. HCG, I told you that I've already discussed this, but one novel approach that in future, if the HCG come in a pen, like a recombinant FSH or like the recombinant, low molecular weight heparin, if it is available in a pen, then if you give 100 to 150 units daily, that will take the care of the luteal phase. And all the expenses the patient is bearing at present of a luteal support can be reduced to only 500 rupees, not more than that, if this pen is available in the market. So there are very good papers that small doses of HCG is very useful as a luteal support. We don't give this. Estradiol, Those who are giving in an IUI, if you give an agonist cycle, then it is to be given. Those who are giving agonist trigger, then the estradiol should always be given to all the patients. Now, last two slides only, that onset of luteal support, it should be started from the day of pickup or next to have, because it will have less uterine contraction on the day of transfer. It should not be later than 3 days. So whether you give it on the day of pickup, 1 day before, 1 day after, 2 days after, the pregnancy rates are same. It should not be more than 3 days. When to stop? When beta-HCG is positive. Nobody does. I don't think anybody in India stops progesterone after the beta-HCG is positive. It can be stopped at 5 to 7 weeks of pregnancy. Common practice is to stop at 10 weeks. But remember, when you are dealing with an FED cycle, artificial cycle, then you should give always for 10 weeks. So just I summarize my talk that luteal phase support is not required in natural cycle. In clomiphene, it is not beneficial. In superovulation with gonadotropin, it is always beneficial. HCG trigger is avoided in patient with high risk of OHSS. GnRH agonist and antagonist are used which demands luteal phase support. Luteal phase agonist trigger, luteal phase support is always required. Agonist trigger is given for OHSS, donor cycle, PGS, PGD and freeze-all policies. Dual trigger and a fresh transfer is very useful. Those who are doing a fresh transfer, I think dual trigger, because it's my routine practice. Whenever I want to do a fresh transfer, I always give a dual trigger and that is very useful. Luteal phase support is not required in natural cycle or modified natural cycle. Results of artificial cycle are the same. Vaginal tablet preferred subcutaneous progesterone has replaced intramuscular route. Dihydrogesterone and SR tablets are under the trial. Low dose HCG may be the option. Start the luteal phase from IUI or ovum retrieval and can be stopped after beta-HCG is positive, except in FED cycle when it is continued for 10 weeks. Thank you very much.
Thank you, sir. That was an excellent talk as always with very clear messages. I request Dr. Praful to felicitate Dr. Nagori, sir. Thank you. I request the chairperson for the next session, please.
I think that was a wonderful lecture regarding the luteal phase support. Whatever we had in our knowledge, at the same time, the concepts of dual trigger as well as the low dose HCG, something like an insulin pen, was a very remarkable concept, and I look forward for this kind of the researches. Whenever we hear Dr. Nagori sir, even if it is a very common subject like luteal phase support, but the lecture 2 years back of a luteal phase support, a lecture 6 months back of a luteal phase support, and a lecture of today's luteal phase support, something very, very new, very, very afresh. Even a research paper of a 2021 has been included in these lectures. So that shows the kind of the outlook as well as the study of Dr. Nagori sir. And we are always enriched by the knowledge of Dr. Nagori sir. Thank you, sir, for giving us the latest as far as luteal phase support is concerned. And one of the important things, as far as all our esteemed members who are sitting at their home and watching this webinar, whatever the questions you have regarding this lecture on luteal phase support, you can ask this question online. And I am very pleased today that after half an hour or so, we are launching our app of AOGS. And that will be a very, very, very novel idea and very dynamic kind of an app where you can interact with the faculties who have participated in this webinar. I think Dr. Munjal Pandya will throw much light on the app also. Now we are having a session, an interactive session on the indigenous dydrogesterone. And I would request my co-chairperson, Dr. Kamini Ben, to introduce our great teacher, the Foxy president, and a very dynamic leader, Dr. P.C. Mahapatra sir. And then I will introduce Dr. Mukund Gurjar sir also.
It is a privilege, sir, to introduce you on this platform. Well, he doesn't need any introduction, but nonetheless, I have to say something for him. He was a professor and head of the department in OB-GYNEC at HCB Medical College, Cuttack. He has governed under his president abilities, Foxy, in 2011. He was an organizing chairperson in 61st AICOG 2018. He was a president in IMA Odisha chapter in 2018. HSSF Bhubaneswar Odisha 2016, organizing chairperson ISAR 2008, and All India Congress of IAGE 2016. He has published many research papers, I don't have to mention many, but still. And he was and has been an invited guest lectures. He has been given so many orations in various societies, including Foxy. He has been felicitated as a genius, Dr. Mahapatra, by Rourkela Society. And I like this sentence, sir, a satisfied soul as a teacher. And it's my honor, sir, to have you here on this platform. Hemant Bhai.
In the same way, we are also having another teacher of teachers, a scientist par excellence, Dr. Mukund Gurjar, as our faculty for today's interactive session. When I was going through the qualifications of Dr. Mukund Gurjar, I was very much surprised, and I think the MCure Pharmaceutical is blessed with such a genius fellow who is heading all the researches for the MCure. He holds 2 PhD degrees from Nagpur and London universities in chemistry and did his postdoctoral research at the York University, Toronto, Canada. He has retired from the distinguished CSIR National Chemical Laboratory, Pune, as a deputy director and the head of chemistry division. He has, to his credit, more than 250 publications and over 180 patents. A large number of research scholars have secured PhD degrees under Dr. Gurjar's supervision. So he is, in a true sense, teacher of teachers. His interest in the synthesis of complex molecules and drug containing chiral centers. As far as his expertise goes, he has developed many chiral drugs for cardiovascular disease, anti-inflammatory, proton pump inhibitors, the non-biological complex iron drugs, and anti-hyperphosphatemia coupled with complex oncology drug, HIV drugs, etc., from the basic premise of his applied research activities. Dr. Gurjar held membership of many reputed journals, including American Chemical Society, Taylor Frankie's, Harvard Academic, and Indian Chemical Society. He is a member of many Indian academic societies. The prestigious Council of Scientific and Industrial Research, New Delhi, has published a portfolio of renowned scientists of all over India, and Dr. Mukund Gurjar appears in that. So we are truly blessed today that 2 stalwarts are going to have an interactive session on dydrogesterone. Please, Dr. P.C. Mahapatra sir, you are welcome.
On behalf of Ahmedabad Obstetrics Gynaecological Society, I welcome Sir Dr. Mukund Gurjar to this hybrid academic front organized by Ahmedabad Obstetrics Gynaecological Society on behalf of MCure Pharma. I welcome you, sir. Hello. So it's truly a hybrid. I am very strong physically, but very weak digitally. But you are very strong digitally. I don't know whether you are weak in physically or not. Well, there was a discussion and a very beautiful discussion on progesterone and luteal support by none other than one of the legendary academician and a clinician par excellence and a teacher, Dr. Chaitanya Nagori, who is very popular, and we have heard a spellbound lecture and a very focused lecture on progesterone. And at the last, the message he gave that progesterone is usually not necessary in pregnancy. If at all it is necessary for a few days or few weeks. That's all. So he has targeted the attempt of abuse of progesterone and misuse of progesterone. I partly agree with him. I cannot fully agree. But certainly I agree that there is a lot of indications for use of progesterone. The expanding horizons of progesterone starting from pregnancy to assisted reproductive technology, IVF, to pregnancy loss, recurrent pregnancy loss, miscarriage, subchorionic hematoma and other things. But now certainly I agree that I see no prescriptions by postgraduates or clinicians. When EPT is positive, one of the progesterone is being added. All pregnancy, whether it's required progesterone or not, that's a big question mark to every gynecologist. Whether we are using for the patient or whether using for the pharma or whether you are using for the physician. That's a big question. You have to decide, but the rationality and indications must be absolutely genuine, number one. Second important thing is the type of progesterone. Since long, in my early days of practice, progesterone was not available, and we are not able to use the progesterone till the micronized progesterone came into the pharmacotherapy. And when the micronized progesterone came, it came by oral route, which they say it can be used orally as well as vaginally. Then the injectable was available, then the gel was available, and now the very good marketing gimmick, the SR was available. And this runs the market, particularly for infertility specialists. This is a part and parcel of the progesterone, and they say that evidence and all that, they've studied worldwide. Then they say that oral progesterone has not to be used, and it's not a scientific basis of use of oral progesterone, micronized progesterone. And vaginal gel or vaginal tablet and then injectable can be of help as a luteal support. And we know that luteal support is mandatory in IVF pregnancy. That also C.V. Nagori has also certified and rationalized that. Because of use of down regulation, you have to use the luteal support in the IVF. IUI is optional, that's all right. Gonadotropins when you're using, that's all right. But natural cycle is not necessary. That is science. Now, then we come as an oral progesterone, which is not a new drug, like dydrogesterone. 6-dehydroerythroprogesterone is the dydrogesterone, which is a molecule by one of the companies which is there for last 50 or 60 years. Of course, we know that I'm prescribing for last 30 years, I know. And it was there long back. But it was kept quiet, silent. Even at the pharma level, it was kept silent. I don't know the reasons why, whether there's a legal reasons, or whether there is a technical reasons, or whether there is a manufacturing problem. None of the companies in the world, except in one pharma, was ruling whole thing. And in the name of patency, that was there. And now, since last 1 year or so, I'm very happy that our own Indian few pharma are producing that dydrogesterone for that. Now, what is this? When we let us again discuss about something about science. There are progesterone, there are various. What is a progesterone? Progesterone is any agent, both natural as well as synthetic, which is able to convert proliferative endometrium to secretory endometrium. Now, the endometrium contains two things. One is a stroma, another is a gland. There are many progesterone. 19-norsteroid is a progesterone, norethistron is a progesterone, medroxyprogesterone is a progesterone. or contraceptive pill, all or progesterone, all causes secretory changes. But there are some progesterone which is able to convert from proliferative to secretory, but stromoglandular synchronization. There are some progesterone which causes stromoglandular asynchrony with secretory changes. Now, when we consider reproduction, starting from implantation and early pregnancy sustenance, we require a stromoglandular synchronized progesterone. And there are two progesterone only who are stromoglandular synchronization. One is a micronized progesterone, another is a 60-hydroxyprogesterone, dihydrogesterone. And these are the two progesterone which is used as a progesterone because this causes stromoglandular synchronization, number one. Number two, they are pure progesterone. They don't have an estrogenic component. They don't have an androgenic component. And they are used only for progesterone. And dihydrogesterone, although it is a synthetic product, that is used as satisfying the reproductive benefit, and that is justified to use it, that none of the other progesterones should be used in pregnancy, excepting only one progesterone, 17-hydroxyprogesterone, caproate, which has now come up as a uterine quiescent effect, not in early pregnancy. Never it can be used in early pregnancy because it's not causing a stromoglandular synchronization. Now, we have discussed. Now, the point today, the second, gynecologists are confused. When to use, that's one aspect. What to use, that is a different aspect. We have already told about micronized progesterone, and for years together, this has been used. Now, when we combine, why we are concerned about this dihydrogesterone, which is also equally effective and used as in reproduction, because it has got certain benefits. The benefits in the sense that for Indian women, vaginal is not acceptable very well. That's one. Injectable is painful and every day you have to give it. That's another disadvantage. And that's why the SR preparation comes to the market, and it's a marketing gimmick. To capture the market, the SR is there, oral progesterone, and having an effect for that. But dihydrogesterone is a molecule which is taking a real advantage over micronized progesterone, as that it can be used orally with the same efficacy as vaginal or intramuscular micronized progesterone. That is why the point of discussion came that yes, dihydrogesterone can be used in pregnancy in various indications, say for example, as a luteal support, as a pregnancy loss wastage, recurrent pregnancy loss, threatened miscarriage, whatever it may be. There are a number of papers flooded here with the comparisons and all that. And of late, the Lotus phase 2 and phase 3 trials all over the world has started this and projected this dihydrogesterone, if not superior, at par with the micronized progesterone, and that can be used particularly in pregnancy conditions. And of late, for infertility, this was used in case of pregnancy loss, miscarriage, recurrent pregnancy loss, since last few decades. But now, the infertility indication of the luteal support, this is essential and can be used as an IVF. I think there are now growing evidences all over the world, starting from Grissinger to BNC, to Dr. Ashok, and in Mumbai also there are some studies by a few IVF specialists for that, used for that, but that has not been Amit Patki. I think these are the few things who researchers who have gone for that. But the problem was there was not a single company was manufacturing that, and the cost factor is a major issue for that. And there are a lot of advantages of that. And if the efficacy is at par with that, in IVF patient, IVF people are absolutely a one-track people. I know CB Nagori must be realizing that. They are absolutely one-track people. They believe in one. And if they are using the same progesterone or same gonadotropin in one company and then getting result, even you give better gonadotropin, they will never accept that. Whatever the result get it, they will think several times to change the product. And same thing happens with the progesterone also. And that is why now they are not being accepted in the IVF program. I asked one of the IVF people, I'm trying progesterone, dihydrogesterone, I'm trying for that. But, and what dose you are giving? Now I'm giving about 20 to 40 milligram of dihydrogesterone along with the 800 milligram of micronized progesterone. I told another again, no, I'm not mentally accepting that. Even I'm using fertility practice for last so many years. This is not being done with that. So there are a lot of, I think, controversies, not only controversies, ignorance, bias and controversies about of the infertility specialist as well as the general gynecologist. And that's why this forum has been organized to clarify some of the issues, whether the dihydrogesterone is a wonderful molecule, better molecule than the micronized progesterone. There are some better aspects of dihydrogesterone, which I've already explained that. But the efficacy of this dihydrogesterone, and particularly nowadays, you people are there and you are the leader in the field of science who has really torn down the situation and broken it. The 50 years of monopoly of a one-off company, I will congratulate you, I will salute you, how you broke that molecule and find out that. So in this context, our audience wants to know, if at all, they know many things about dihydrogesterone from the literatures and all that. I want to know from you about the technological part of manufacturing, because this is important. I was also surprised that for last 60 years, why one company is producing. Second important is that a very multinational company manufacturing dihydrogesterone in only one plant in the world, that is in Amsterdam, nothing other than. They could have done multiple plants because the demand is more. And why? I was asking them long before also, why the one plant is there, that's there? And the answer at that time they were telling, it's very critical. And the manufacturing process is very critical to break down and convert into retro positions and all that, by which technology high power is necessary and other technological problem are necessary. That's why it can be done in only one plant only. So that is really surprising. Even that company could have established many other centers because the demand is more. They could have done it. And fortunately, you came out and a God-gifted scientist who found out a new technology of making this retroprogesterone at par, and you have done a lot of studies, both in vitro and in vivo studies regarding the bioactivity, regarding the impurities and comparison to the innovator molecule. And now it is a proved molecule and established molecule which has already been marketed in India. And we want to know what is the tricks of that. Why you are silent? Why other people are not doing? Why the Abbott company also has not other plans for that? And what is a new technology? Are you following the same technology as of them or a different technology? And I feel that you are having an indigenous technology. India genius is indigenous. And therefore I find that indigenous technology, if it is there, we will also accept it and we'll try to grow and promote with that. Because with that also the cost factor could be reduced. But we cannot say that you do a technology which doesn't have any side effect, but doesn't have any effect also. That also we don't want it. So a product which may have a side effect would have an effect. If the efficacy is there, if not superior, at par with the innovator molecule, all gynecologists here will accept gladly and garland you on this forum about that. And therefore, Dr. Gujar, I welcome again and clarify these issues and tell something about the evolution, how you came across the MCure Pharma, whether the MCure Pharma has kidnapped you or you are voluntarily joining this company, or you are basically a researcher and find out something for the country India and fame for you fame that yes, I will be boasting as an Indian to find out some remarkable thing in India. I will congratulate you and clarify some of the issues. People are wanting to know that.
Omkar, can I have my slides, please? Good evening, doctors. You can hear me, isn't it? Yeah. I have been asked some questions, regularly. So I am giving a small presentation of 7-8 slides to indicate the answers to these questions which are often asked. The source of progesterone is asked, where you are getting it from. Then the synthesis is the photon bombardment strategy, which is same as that of Abbott's. Then, more important is the purification, which we are using a very high advanced preparative chromatography. And for characterization, we have used the XRD, the single crystal XRD, NMR, IR, mass. These are the very profound spectral studies which are normally used to identify the molecular structure of any molecule. And we have compared all these spectral studies with the innovator and found out that they are exactly the same, compatible, superimposable. And then, I will also discuss about the spatial structural assignments, the diagonal angle between the rings B and C, which is very important for the activity of dihydrosterone. Next slide, please. Next slide.
Slide change.
There are basically three sources of progesterone: from soya oil, Mexican yam fruit, or algae. Soya oil is enzymatically converted into an intermediate called bisphenols, and in 3 steps you get progesterone. Mexican yam is isolation of another steroid, which in 5 steps can be converted to progesterone. Algae also, the isolation is stigmasterol. 5 steps again you get progesterone. And progesterone obtained from all the 3 sources are identical chemically and physically. Next slide. So I've seen that soya oil gives you bisphenol and convert it to progesterone. And this is the technology we use it to get progesterone, which is a starting material for dihydrosterone. Next slide, please. The most important aspect of progesterone and dihydrosterone is the stereochemistry at 9 and 10. I have given here, if it is a dark, it is above the plane. If it is like this, then it is below the plane. So the arrow indicates the stereochemistry of the molecule. In case of progesterone, this Me group is above the plane, and this hydrogen, this H at C9 position, is below the plane. And what we have to do is that we have to convert into exactly reverse the stereochemistry at C10. Here the Me is alpha, that is below the plane, and here the hydrogen is beta, that is above the plane. These are the 2 transformations which you have to do to get progesterone into dihydroprogesterone. But these are very critical. What we have to do is, we are now protecting the groups which are not required for any reactions. We can deprotect at the end. We are putting a double bond, which is very critical for opening the ring. You open the ring and then you close the ring. And this is the trick in that. You have to open the ring with the light photon bombardment at lower wavelength. You get this open chain, and then you again bombard them with a higher wavelength to close it back. And when you close it back, you change the positions of this methyl, which was above the plane, below the plane, hydrogen below the plane and above the plane. And then, of course, you deprotect it and purify it, you get digosterone. So this is the technology which we have adopted. We have used it. Why? I don't know why others have just started coming. We were working for our American subsidiary, vitamin D, and in which the photon bombardment reactions were involved. So we have developed the fundamental chemistry in the lab. And then our marketing people say that since you have the photon bombardment chemistry, then why don't you use that particular thing to make dihydrosterone? So this is the way we were involved with the synthesis of or manufacturing of dihydrosterone. Next slide, please. These slides indicate the single crystal X-ray. This is the ultimate proof of any molecular structure of organic compound. If you look at it, this is the X-ray of progesterone. It's a flat molecule. And if you look at the XRD of dihydrosterone, you can see that the CD ring and AB ring are bent. And this is very, very critical. And this angle should be 60 degrees. And we have seen from the XRD, which we have done it at National Chemical Laboratory, that the angle is exactly 60. In the next slide, we have also isolated the dihydrosterone from the innovator sample, developed the single crystal, and did the single crystal XRD. if you look at it, the white is MQR's dydrogesterone single crystal X-ray, and the green one is the innovator single crystal X-ray. And you can see they're superimposable. They're superimposable, so there is no doubt about the chemical structure of this molecule. And if you can see that there is an angle of 60 degrees here, which indicates that the molecule has got this spatial arrangement which are required. Next slide, please. The single crystal X-ray is an absolute method that can unequally confirm the composition and molecular conformation of API, which we have done it. Dihydrofuran containing dydrogesterone API is analyzed by single crystal XRD and found to have the spatial orientation in which the hydrogen atom present at C9 is beta and methyl group at C10 is alpha. If you can see it here. Just juxtaposition of hydrogen and methyl are opposite to those of progesterone and therefore bend the spatial geometry of dydrogesterone, giving rise to 60-degree angle between the ring AB and CD. These structural changes in dydrogesterone compared to progesterone make more orally active and metabolically stable. Next slide, please. We have also isolated the dydrogesterone from Abbott sample, and this is the HNMR, the proton NMR spectrum, and you can see both of them are exactly superimposable. Next slide. This is the carbon 13 NMR spectrum, and look at it, all the peaks. This is the Abbott sample and this is MQR sample. They are exactly superimposable. Next slide, please. So just I wanted to impress upon you that the dydrogesterone which we are making manufacturing in India is exactly the same as that of the innovator sample. And all the parameters, like all the spectral studies, XRD, everything, we have used it to prove that our product is same as the innovator sample. Thank you very much.
Thank you, Dr. Gurjar, for informing the gynecologists who are very poor in physics and chemistry, and that's why they have come to biology, and that's why they have entered into the medical sciences. But little bit we know about progesterone, that it is a CPP molecule, cyclopentanoperidrophenanthrene, where 3 6-carbon atom with 1 pentane group is giving rise to a 21 carbon atom compound, progesterone. That's everybody. That's the basic thing we understand by steroidogenesis. But it's very good that you have devised this. But I want to know whether the same technology, photon bombardment, is there in Amsterdam as well as in Pune. Both same.
Yes.
So same. They are also in the photon bombardment technology is there for that.
Yes. Yes.
And the idea came from vitamin D that you switched over. That it's better that you switched over to the gynecological segment. From the vitamin D, you get a knowledge and concept.
Yeah, we have developed the platform technology of photon bombardment, and then we are using this particular technology for many molecules, in the research and development labs.
And thank you very much that you have already compared it in vitro about compared with the innovator molecule, about the impurities, about the efficacy and all that. But ultimately it boils down to the result. And here are the gynecologists who will test it, use it, and then only feedback that whether it's a good or bad. If it is good, they will accept it, or if it is bad, they will reject the product as well as reject the company also. You accept that?
I assure you that this will not happen.
Yeah. So this is I also say that you are India genius is indigenous. I respect you, and you are really making a fame of the country, name of the country by settling here and at least contributing something to the improvement of the science and finding out a newer molecule where the bending could be possible by photon bombardment, and we are convinced about it. But the time will say whether this molecule has a equal efficacy as the innovator molecule, and the expanded use or indications of this dydrogesterone will be more popular for that, because we know that progesterone is a part and parcel of all gynecologists and obstetricians, right from the UPT positive, they use it till the delivery, and even after that also progesterone, as if it is necessary for all pregnancy and all that. But at the same time, I will request that yes, the reasons of expanding use and horizons of use, indications of progesterone should be there. I encourage that. But at the same time, the misuse and abuse should be restricted further. And as a man of science, I think this, I will have a message to the gynecologists that they will use it. And I hope and I wish that this indigenous molecule will be not at par with the innovator molecule, will one step ahead of the innovator molecule, so that our Indian patients will be benefited, and for the women's health it to be a real gift, so that people, Indian women and pregnant women, will remember not only gynecologist but Dr. Mukund Gurjar for all time to come. Thank you very much.
Thank you.
Thank you, Dr. P.C. Mahapatra sir and Dr. Mukund Gurjar sir, for wonderful interactive session. And Dr. P.C. Mahapatra sir has rightly said, the proof of the pudding is having the pudding, eating it, testing it, and then giving the opinion about it. But anyways, dydrogesterone has a very promising role, and we are all convinced about it when we use it for the early pregnancy salvage. So let us move on to another occasion of today's seminar, and that occasion is launching of an app of AOGS. I am very pleased, and I must congratulate the new team, Dr. Jignesh Deliwala as a president, Dr. Munjal Pandya as the honorary secretary, that they have started with a bang. This is the first CME, and in the very first CME, they are coming with a very new app of AOGS. Although AOGS app was started by Dr. Kiran Bhai when he was the president, but that was an era of the app in their primitive stages. It was much more stationary. The lectures as well as the materials were static, while this app is now going to have very dynamic features, like our all webinars or the physical CMEs will be uploaded in this app. We will be getting the notifications of this app on our mobiles. All AOGS members who are registered in our AOGS directory. So like any other app that we are having in our mobiles, we will be getting the notifications as and when there are new programs or there are some new features related with the app. We'll have the interactive sessions also, where regarding any CMEs, if you are having any questions, any queries with the faculties, you can upload this on the app and you will get a personalized answers also. So these are the features of this app. Regarding this app, I think Dr. Munjal Pandya will throw some more light on this app. And after that, we'll have the formal launch and the inauguration of this app. I welcome Dr. Jignesh Deliwala, Dr. Munjal Pandya, and Dr. P.C. Mahapatra sir, Dr. C.B. Nagori sir, Dr. Kamini Ben, Dr. Hital Ben, Dr. Snehal Kale, our honorary secretary, and all the managing committee members who are present over here to come on the dais so that we can have the formal inauguration and the launch of the app. Can we have the video regarding the introduction of the app, who are present over here to come on the. Okay. Before we just launch the video of the app, it is our privilege and the pride to welcome and to felicitate both the faculties, Dr. C.B. Nagori sir. Nagori sir, we have done the felicitation. Dr. P.C. Mahapatra sir. And I would request Dr. Jignesh Deliwala and Dr. Munjal Pandya to present a wonderful memento of Sardar Vallabhbhai, the Statue of Unity, to Dr. P.C. Mahapatra sir. Thank you, sir. On behalf of Dr. Mukund Gurjar, sir, I would request one of the senior representative from the MQ Pharma to come on the dais and receive the memento for Dr. Mukund Gurjar. Thank you, MQ Pharma, Dr. Mukund Gurjar, for a wonderful introduction of the dydrogesterone. Thank you. Now we are starting our video of our app, just an introductory video. MQ Pharma, Dr. Mukund Gurjar, for a wonderful introduction of the dydrogesterone. Thank you. Now we are starting our video of our app, just an introductory video. MQ Pharma, Dr. Mukund Gurjar, for a wonderful introduction of the dydrogesterone. Thank you. Now we are starting our video of our app. Now we are starting our Before we play the video of MQ Pharma, I would request Munjal to say something about the app. Although I have thrown some light, but Munjal is, he has been in for developing this app and he has contributed a lot about this app. Munjal.
Thank you so much on behalf of Team AOGS. As sir said that it has been previously launched by Dr. Kiran Desai sir. The platform was old enough and not to upgrade the app on its own. So we had to make a new app along with a new website because both the platforms were old enough not to get updated. There are various versions, various tabs inside that app as we saw in the video, and we'll be sharing all the informative video with regards to this particular app in official groups. So we can have your feedback for this app and your views with regards to app, and they are most welcome. As well as with regards to website, we would like to have your feedback so that we can improve upon both the websites and application. Both of them are actually dynamic. We can have the changes according to your feedback as well. So we would like to have your feedback, honest criticism as well. But we need to make it an interactive app because usually what we do is around 4 to 5 years we spend with our mobile. So obviously we are intelligent enough to spend it creatively, but again it will be an addition of gynec perspective or the society with regards to this app. And we have one new tab with website and application, that is AOGS Clinical. There are 3 different tabs in that. One is RCH program, the other is PG Symposium. As of now, we have not started with RCH activity because of the COVID constraints, but we would soon do it, and we would try to record it so as to make it available on YouTube channel. The PG Symposium does have one webinar that we did with postgraduate students, and all the programs and the symposium is having a YouTube logo. When you click it, the YouTube link
link of that particular webinar will be opened. And again, there will be PDF available of that particular program. So we have a storage of a lot of information inside that particular app. Though it is of a few MB, but it does have a lot of information if we use it creatively. So we welcome all the feedback from you all, and I thank Delivala sir. Yeah, I thank Delivala sir, Team AOGS, and Shashwat Bhai as well, because we worked very hard with this particular app, and Mr. Ankur Bhai for making it possible for us. It took like 4 years when we started off with this particular thought. And iStore, people would need to wait for 2 more months, because usually iStore would take 3 months for approval, as compared to Android, which would take only 15 days. And we did a lot of changes with regards to the approval process. Like thrice we applied, and finally we got the permission. So it is almost a dream come true, but it is actually true only when we utilize it optimally. And I wish we do that. Thank you so much. Thank you.
The best part of this year's AOGS team is most of them are very, very young, very, very dynamic, very, very enthusiastic and energetic. And that augurs well as far as the future of AOGS is concerned. All are so promising that we look forward for a very bright future of AOGS, SOGOG, as well as the FOXY. All the best and a heartiest congratulations to Dr. Delivala, Dr. Munjal, and the entire team of AOGS. I think through this app, we can also have the link to the YouTube, where we will be able to see all our webinars, as well as if we are able to record our physical conferences from now onwards, that will also be uploaded on this app. So it will be a kind of a permanent academic material on the app. So you don't have to visit the libraries, or you don't have to visit the textbooks, and you can get a ready-made material regarding all the subjects of obs and gynae and infertility and so on. Now we are moving on the last session of our CME today, and that is about the vaginal surgery and how the vaginal surgery can help us as far as benign conditions of the uterus is concerned. And when there is an, you can say, the all-around era of an endoscopy, the popular theme or the song that is going gaga all over India or perhaps the world is about endoscopy, and most of the time it is truly so. But in that also, there is one Mahendra Singh Dhoni in gynec surgery, and who is none other than Dr. P.C. Mahapatra sir, who has always advocated that benign conditions of the uterus can always be tackled very smartly, very efficiently, and with lesser amount of incidences of any complications through vaginal route. So he has advocated vaginal surgery like anything, and he has truly guided so many students and so many representatives in most of the conferences that has happened all over India, that some of them and many of the persons or the obstetricians and gynecologists who are interested in doing non-endoscopic surgeries, they were truly encouraged by the advocacy of vaginal surgeries by Dr. P.C. Mahapatra sir. And before Dr. P.C. Mahapatra sir come on the dais and give us the knowledge about all the roots and the real treasure of doing the vaginal surgeries for benign conditions, we will have a 1-minute video of MQ Pharma, and then Dr. P.C. Mahapatra sir will deliver his lecture. Thank you.
Dydrofem. Dydrofem is bioequivalent to Innovator at 25% lower cost. It is made using complex photon bombardment and purification process. Dydrofem's structure is exactly like the reference dydrogesterone structure. This brand is brought to you by Dr. Mukund Gurjar, rated as one of the top 75 scientists in India by CSIR. Dydrofem is brought to you by MCure, India's #1 company in women's health, most trusted by gynecologists. It is for patients with recurrent pregnancy loss, history of miscarriage and defective luteal phase. It has better potency, bioavailability and tolerability than progesterone. Dydrofem, MCure's dydrogesterone, proud to be made in India.
Revered office bearers of this vibrant society, Ahmedabad Obstetrics Gynaecological Society, the current president, when Jignesh called me that we are very happy to know that you are coming, I was really reminding of all of you, starting from Hemant to our sir, C.B. Nagori, and my beloved Beneath, and many people here in Ahmedabad society. And I thank Rajiv for giving me an opportunity to have my first physical educational CME program in this country. And when he asked, I selected Ahmedabad as the #1 CME for that. I thank MCure and especially Rajiv for the academic endeavor physically, because I always say that yes, virtually it's a fact that I'm digitally very poor and physically strong, as paradox to Beneath and other people like you and Aap and all that. I don't understand anything on that. I'm reminded of two very beautiful English words by Swami Vivekananda. And now I am recollecting those. Two beautiful English words, one is connect, another is connection. And now I feel after the corona issues, and the improved technological advances, in particularly the mobiles and the digital era, where connect is very good, but connection we don't have. And here I have come down from Bhubaneswar to Ahmedabad to have a connection along with the connect, and that's why I'm here. Well, and again about the topic, I was being told that yes, you'll be talking on different subjects other than progesterone, dydrogesterone and other things which will be covered by everything. But again, I was forced to be the interactive session. I didn't know, I was not aware of that. But fortunately, it went up very well. And Rajiv has done a fantastic job in coordinating everything. And Jignesh requested me on telling something on hysterectomy and telling on the vaginal route. Because he told that laparoscopy and all that has prevailed everything. But I feel that Gujarat is the only state who had promoted vaginal hysterectomy as well as laparoscopic hysterectomy. And therefore, there is a fight between laparoscopic hysterectomist and vaginal hysterectomist. And that's why I want to solve it. I am not confident enough to solve that, but I'm sure that all of you do a lot of both vaginal hysterectomy as well as laparoscopic hysterectomy. But as a man of science, I must say that whether it is the need of the patient or mood of the gynecologist. It is not the mood of the gynecologist. It is the need of the patient for which surgery has to be taken up for that. And that's why I will speak on this particular topic in the late hour, whether I know that all of you have lost patience and all that, but I will skip many of these things for that. Well, paying homage to the eternal and immortal soul, Dr. Behram Ankalesariya. I remember those days wherein Foxy, we from our societies and Ahmedabad societies first interacted in Calcutta when Rajan was the president of Foxy. And at the first sight, there was a love. There was a tremendous love. And from then onwards, till date, the society of Orissa and society of Ahmedabad became one. And that is another reason for which I prefer that I should come down here. And I pay homage to the eternal soul. When I was a vice president, he was the president. And he was physically very strong, digitally weak. And physically, I am also strong, digitally very weak. And that's why our philosophy matches each other for that. And I still remember him when I come to Gujarat or Ahmedabad. And we have learned many things on Corona, digital era. Now we are entering the physical. As I said, particularly a teacher for last 38 years, the digital can help, can be an adjunct to the teaching program. But I think face-to-face is something different. As a teacher, there is a lot of studies. I was doing a study in my college, chalk and duster versus PowerPoint. There is a difference. So the eye-to-eye contact gives a better impression of a transfer of knowledge than the digital. There is no doubt about it. But at the same time, digital has got many advantages. So there is a need for a tech versus touch. Like that, technology has improved. And based on the technology, telemedicine and all that, can you say that we cannot see the patient and by technology we can do the treatment? It's not possible. So there is a need for blending of tech and touch. And I bring greetings for the place of Lord Jagannath. And therefore I will say that status of hysterectomy, past, present and future, and what are the changing trends and changing techniques for that. These are some of the legendary stalwarts who has devised, who has thought of removal of uterus. There is a need for hysterectomy, Ephraim Magdwell. Thinking there is a uterine tumor, patient coughed, and the whole tumor came out, it could be, and it turned out to be an ovarian tumor. And he did it in an era where surgery was never thinkable. James said, Mariam Sims is a known person as a surgeon par excellence, who has given many innovations in surgery for gynecology. Howard Kelly, Charles Clay documented hysterectomy, and Conrad Langenbeck, vaginal hysterectomy. And there was a thing that he single-handedly did it because his assistant, a gouty patient, gouty doctor, fell in, and at the time collapsed when he was the only surgeon, and there was a bleeding. So how to put a ligature? He applied the teeth, he applied his hand, and he applied his leg, and put the nut for that. There's a record, Langenbach. And there are many surgeons in India also who have devised the technique, and there is a changing techniques and changing trends still today. So today's innovations are tomorrow's history. One can only hope that the surgeon of the 21st century will not judge us too harshly and will realize that we are captives of the time in which we practice. So don't criticize. I always tell my fellow mates, don't criticize your seniors, your teachers, what they are doing. There are a lot of bleeding and all that. Now don't criticize because you have got the electrosurgical gadgets, you can control it and all that. Give a credit to them. They are captives of nature in which they are doing it, and they have done a fantastic, a better job than you. And therefore, as time passes by, newer technology can come, and don't boast of yourself. It was notably anesthesia which robbed surgery of its horrors, asepsis which robbed of its dangers, and cellular pathology which came as a godsend to enable the operator to discriminate between malignant and non-malignant groups. And past, what was there in hysterectomy? No anesthesia, no diagnostic armamentarium, no ultrasound, nothing, no gadgets. Only 2 fingers, 2 eyes, 2 cerebral hemispheres. No knowledge of asepsis, no knowledge of blood transfusion, lack of instrumentation, no hemostatic measures, and survival becomes a big question mark. So surgical will rather than surgical skill was more important. They were will of doing this, and from that, skill has developed for. Present scenario, what are the advances? Diagnostic armamentarium. Sonography is a big advantage. Laparoscopy is a big advantage as far as the diagnosis is concerned. But at the same time, there is a change. Profile of patients have changed. Profile of physicians have changed. And places have changed also. Our profile of patients, the patients have changed so that we are in a medical legal era. People are after us. They have a lot of expectation. The patients have a lot of expectation. And profile of patient, the treating in that circumstances becomes more conversant. Improved anesthesia, blood transfusion facility, knowledge of asepsis, knowledge of surgical anatomy and reproductive physiology, equipments and gadgets, surgical skill we have developed, computer, electronic era, bioengineering, and technological innovations are bound to have a new and changing circumstances and changing strategies. Now, while coming to the operation, particularly for hysterectomy, there are valid reasons to operate, one must find out. To save life, to relieve suffering, to correct significant anatomical abnormality, or to allow for creation of life. These are the four valid reasons to operate. So it's not the mood of the surgeon that you will operate and show his surgical skill. The need is important. That is to be a prime concern for that. The hard facts regarding hysterectomy. Hysterectomy is the most common operation performed by gynecologist and surgeon. Second most common major surgical procedure in females next to cesarean section. I remember in this context, 15 years back, I was going as an external to the different universities for postgraduate examination. I was asking them what are the indications of cesarean. They say beautifully fetal indications, maternal indications, all these in a very classical manner. And hysterectomy, benign conditions, malignant conditions, these are the diseases and all that. Now I'm going as an examiner after 15 years. The examinee are telling, if I ask what is the indication of cesarean, sir, presence of pregnancy is an indication of cesarean. And what is the indication of hysterectomy? Presence of uterus is an indication of hysterectomy. So it is so simplified, obstetrics and gynecology have been so simplified. So this is a terroristic approach. It's not a scientific basis for that. 600 lakhs hysterectomies are done per year in United States. 30.4 per 10,000 women in UK. 1 out of 3 is deprived of uterus by 16 in USA. And Indian statistics is as usual. We don't document it. It must be much more than what is there. But it is not the total incidence of hysterectomies, but unindicated intervention is also important. There are very many unindicated interventions. And there was a study in which earlier hysterectomy was number 1, unindicated surgery. Now we are very fortunate that we have come from first position to third position. First is cardiac intervention is number 1. Second, joint replacement. And third position, we have got still hysterectomies, they're unindicated, without an indication doing the hysterectomy. Basic concept of any surgical procedure. What is the basic concept? Selecting the right patient for the operation, who are the patient needing surgery. Second, selecting that there are 3-4 modalities of surgery. If there are 3 routes of hysterectomy, selecting the right operation for that particular patient. Third is performing the operation correctly, the skill, technique. And then if it follows, post-op care, you forget it. You do it and forget it. Majority of the post-op complications arise from the intraoperative thing. So you do in such a manner that you don't look into the patient post-operatively. And in gynecology and pelvic surgery, another important thing is knowledge and understanding of physiology of reproductive organs, pathology and clinical manifestations of pelvic disease, and dynamics of psychosocial and sexual development should be necessary. It is not just a craftsmanship of removal. These are all important parameters while doing a pelvic surgery in a females. Now, what is the status of hysterectomy? These are key issues. Status of uterus to be removed. First you analyze, think about it. Status of the surgeon, you yourself analyze. Status of route of removal and status of changing trends and techniques. I will focus these two, status of route of removal and status of changing trends, as Jignesh has pointed out and stressed. But before that, I must say that status of uterus to be removed. As I said, the sole purpose of uterus, what is the sole purpose of uterus? Is procreation, and after procreation, creation of diseases. So, one must think that after procreation is over, why to wait for creation of diseases? You remove it. This is a terroristic gynecological approach. As I have told, the presence of uterus is indication for hysterectomy. This should not be. Status of uterus to be removed. All of us remove uterine pathology, cervical pathology, adnexal pathology, pelvic floor pathology, obstetric pathology, disease of adjacent organs, stellus, all these. But analyze how a simple uterus is being removed, innocent uterus is removed because of pelvic floor. Simple uterus is removed because of AUB, where endometrium is defective. You are removing the cervix, you are removing the myometrium. Why the whole uterus? Think about it. Obstetric pathology, there is another indication. Disease of adjacent organs. If the ovarian cyst is there in elderly, because of the age, because he has completed family, you remove, chop out everything for that. And even in a case of malignancy of rectum, our surgeons tell, you remove the hysterectomy, innocent uterus, you remove it, I will have a better clearance and I will remove the lower part and do a radical surgery for that. And in some countries, there is a sterilization method. Is it acceptable? And another very good important terminology is CPP, chronic pelvic pain. If there is a chronic pelvic pain, is it a uterine pain? Chronic pelvic pain because of the cystitis, because of appendicitis, because of psychogenic reasons, you remove the uterus. So that is also indicated for that. And there are a lot of unindicated surgery that I will point out. And first of all, from that, we know that you have to identify whether this patient needs surgery or this patient needs some other treatment for that. Even no pathology. If no pathology, I was just telling, one of the patients came to me, menorrhagic cycle, 3 months, and 40 years, completed family, and everything is normal. Uterus is normal, cervix is normal, sonography normal. One of my students advised for hysterectomy. I phoned, you have seen this patient, you have advised for hysterectomy. What is the indication? Sir, there is no indication, but if I won't do it, she will do it. If that is the indication, then I have nothing to say for that. So these are some of the unindicated surgery. The ease with which the average hysterectomy may be done has proven both a blessing and a curse to humankind. There is no doubt that a hysterectomy done with proper indications may restore a woman to health and even save her life. However, in the practice of gynecology, one has ample opportunity to observe countless women who have been advised to have hysterectomies without proper indications. I am inclined to believe that the greatest single factor in promoting unnecessary hysterectomies is a lack of understanding of gynecological pathology. The greatest need today among those who are performing pelvic surgery is a better knowledge of gynecological pathology. Tilleen has told long back. Now coming to the status of surgeon, gynecologist versus general surgeon. I have seen all across the gynecologist, if the wife is a gynecologist, husband is the surgeon. Wife brings the patient and surgeon is the surgeon who is doing a hysterectomy for that. I strongly condemn this. I told the gynecologist that you have to caution your husband that don't go below umbilicus. Below umbilicus is our field, above umbilicus, whatever you do. And you can be a standby and help me if there is any need for that. But majority till date, everywhere, all over India, I have done, and the surgeon does the case. Adequate knowledge in surgical anatomy and more than adequate knowledge in pathophysiology is essential. I'm giving a simple example. When I was in a workshop, in endoscopy, a TLH was being performed by a general surgeon in Hyderabad. I was just a chairperson. Absolutely brilliant surgery. Fibroid uterus, multiple fibroids, 12, 14 weeks. Not a drop of blood was there. So there was a really enchantment amongst the public in the audience. They clapped it, they praised, everybody praised the surgeon and all that. But the surgeon, why no, he poked me. He wanted opinion from me. Then I commented, the dissection is fabulous, fantastic, but the decision is dangerous. Then immediately they calmed down. I commented, the decision is dangerous. I said, in a 38-year-old lady, for benign conditions and a multiple myoma, with a normal ovaries, you have chopped out the ovaries. That's a wrong decision on that. Hysterectomy is justified, but decision, who is giving a decision for that? Because he is a surgeon, he is not able to give the decision for that. So therefore I told, decision is dangerous, dissection is fantastic. He really regretted all the essence of the standing ovation has been dropped down immediately for them. Surgical skill, commitment and expertise is important. Set up gadgets and team gadget oriented surgery. Ethical, rational and more human should be there. Status of route now. Vaginal you can do it, abdominal you can do it, laparoscopic you can do it, and future. My anesthesia professor once told me, Dr. Mahapatra, we have seen removing the uterus by abdominal route. We have seen uterus removal by vaginal route. We have seen uterus removal by laparoscopic route. We are waiting for another route, how you deliver it. Either by rectal route or some other route. I think At that time I told, no, I'm waiting for another, I think without any surgery, how the uterus will be removed. You enchant a mantra and the uterus will be removed and give it to that. I'm waiting for that time for that. So future is uncertain. We do not know in which way we do this. But the first vaginal hysterectomy was way back in 1813. And first abdominal was 1863. And first laparoscopic hysterectomy in 1981. So earliest recorded history is a vaginal hysterectomy. But when you think nowadays, when your only tool is a hammer, every problem will look like a nail. And only when you have a laparoscopy, you want to put it in every case and do the surgery for that. That's wrong. Abdominal hysterectomy, more than 80% performed in UK and USA. Technically easier. Access and visualization of abdomen and pelvis is there. Enlarged uterus, adnexal pathology, previous pelvic surgery, pelvic pain. Nowadays, our main aim, this is an invasive surgery. This is a big hole surgery. And the morbidity is more. And that's why we want to eliminate that and substitute alternative like abdominal, like laparoscopy or vaginal, which is a minimal invasive surgery. But at the same time, I can say now, in the present context, abdominal hysterectomy has not gone to graveyard. There is still some indications of abdominal hysterectomy. Those who are proponents of endoscopy, those who are proponents of vaginal surgery also. I am not a proponent of route. I am a proponent of science. As a teacher, I can say whatever is best, you can do it. I have seen many cases where repeated surgery has been done, uterus is not visualized, even by laparoscopy, you cannot see anything for that. And all scars are there. There is a place of abdominal hysterectomy also. There is not, you can't deny that. So even whatever expertise you develop it also. Every uterus can be removed. I don't believe in that. So it's a conventional practice. Vaginal hysterectomy advantage, oldest recorded in history, familiar with gynecologists because the vagina is the only route where I always say big hole surgery versus keyhole surgery versus no hole surgery. So big hole surgery is the laparotomy. Keyhole surgery is a laparoscopy, which is a non-invasive, which is a minimal invasive surgery. And no hole surgery is vaginal, which is a non-invasive surgery for that. And it's a signature of the gynecologist. That's a very important thing. Reduced mortality, morbidity, obese, elderly, high-risk subjects, rapid recovery, shorter hospital stay, minimal blood loss, minimal instruments, minimal complications. And what is the disadvantage? No glamour, no money. If you get more in laparoscopy, you can't get more in that. Surgery of minutes rather than hours. Need for good anesthesia and light assistant. It is difficult to learn, but once you learn, it is easy to do. Challenging situations are there, need for meticulous surgical skill and non-complacency. And don't think that is a blind procedure. Those who think that is a blind procedure, we can't see the dangerous surgeons. It's not a blind procedure. You see and cut, don't cut and see. This is the surgical philosophy. Surgeons usually cut and see. We gynecologists see and cut. That is the difference between surgeon and gynecologist. Laparoscopic hysterectomy, scope has been broadened. Definition, classification, merits over abdominal vaginal hysterectomy, types, technical aspects, advantage, disadvantage, complication, all these you know it very, very well. But I tell all my junior gynecologists, be an endoscopic surgeon. Don't target to be a TLH surgeon only. They're only targeted for one TLH. They don't know how to do a hysteroscopy. They don't know how to do a fertility promoting surgery. They don't know how to do other conservative procedures for that. I think that is not science. That is not growth. Other key issues, subtotal versus total, LAVH versus TLH, ovarian conservation versus removal. That's again a debatable question. Clamp versus clampless, suture versus sutureless. Nowadays, sutureless is there. You apply vessel sealers. Staged versus joint procedure. You can do two surgery, LAPCAL as well as hysterectomy. Completion versus conversion. And if at all there is any problem, don't have an ego. You convert it. There is not a problem for that. Don't sacrifice at the cost of the patient. Complete the procedure by any means, and creating complications is not a science. Now, oophorectomy. What are the facts and fictions during hysterectomy? Benign conditions where healthy ovaries there. That ovaries after long years of dedicated service is not able to retire gracefully. That's all right. But when that you give a compulsory retirement by doing it, the ovary will be irritated and transmitted to every organs and giving rise to postmenopausal symptoms. That discrimination in terms of dignity and respect exists between male and female gonads. How many male gonads are being sacrificed? That female gynec surgeons chop off ovaries more frequently than their male counterparts. That ovarian cancer phobia is inherent amongst gynec surgeons, and that's why they remove it. That it is easy, very easy to put a clamp lateral to ovaries during abdominal hysterectomy or laparoscopic hysterectomy. Then put clamps medial to ovaries during vaginal hysterectomy because it's technically easier. That unilateral oophorectomy reduces the future chance risk by 50%. This is absolutely wrong. So decision of hysterectomy, decision of removal usually depends on some rationality. So if you are, there is a saying that if you are not able to convince, at least confuse. I am not confusing you, but the total consensus I am giving you, this is the consensus of ovarian removal versus preservation. Organ preservation and conservation is essential theme of the millennium. So try to conserve the ovary, but in some cases like postmenopausal and risk factors for ovarian malignancy, you have to have a radical hysterectomy. If there is a strong family history of ovarian malignancy, if there is a BRCA positive, even at the age of 35 also you remove the ovary. Age is only arbitrary, not rational. People say that 40, remove it. This is arbitrary. Adopting proper surgical techniques, unilateral oophorectomy, only psychological bias. HRT is mandatory here, lack of evidence-based statistics for that. So it is important for the surgeon to select the operation that is best for the patient, not the one that is best for the surgeon. All uterine that can be removed vaginally can be removed by the abdominal route or by lap hysterectomy, but the reverse is not true. There is a global reduction in the incidence of abdominal hysterectomy and a concomitant increase in lap hysterectomy and vaginal hysterectomy. Only when vaginal hysterectomy is contraindicated, lap hysterectomy should be considered. And when lap hysterectomy is not possible, abdominal hysterectomy has to be considered. This is absolutely true. And all the evidences across the globe, victim says, then when vaginal hysterectomy is feasible, laparoscopic hysterectomy is to be condemned. Adequate training is an essential component for the optimum result. And there is an igniting change now. After the vessel sealer has come, there is an igniting change of doing a sutureless procedure by vaginal hysterectomy. It's a simple procedure for complex pathology, simplicity, patient-friendly, surgeon-friendly, and minimal invasive technique where future will answer. The basic principle is a bipolar technique for that, and a vessel sealer. The basic surgical philosophy earlier was what? The surgical philosophy, which vessel to be coagulated and which vessel to be sutured. The basic surgical philosophy, any vessel which has a name to be sutured, any vessel which doesn't have a name to be coagulated. So uterine artery is a name, it should be sutured. But yesterday's contraindications are today's indications. When a vessel sealer can seal 7 mm vessel with least lateral spread, that philosophy doesn't hold good now. So that is absolutely clear that bipolar is a very important sealing system, is a very advantage is there, and we can do that. And scope of non-suture hysterectomy has been increased for that. So why non-suture? Inadvertent pricks and hematoma, the demerits of suture, slippage, pain, infection, adhesion, foreign body reaction and all that. Merits of sutureless is say bipolar, least lateral spread, reduced thermal damage, vessel sealing, auto-sensing, auto-stop mechanism, least smoke, least tissue damage, rapidity of the procedure, reduced cost of the suture materials, psychologically gratifying to the patient. So the present scenario, these are some adversities of hysterectomy. Unindicated surgery, again think about it. Techniques, need of the patient or mood of the surgeon. Role of general surgeons, unethical practice, non-evidence-based procedures, commercialization of profession, medical scenario, altered doctor-patient relationship. So we are practicing in an era where literate patients are there, complex surgeons are there, adverse society are there. Basing on that, you balance and do the surgery what is best as per science is concerned for that. So the most serious mistakes in the practice of gynecological surgery may be made by those who know how, but have not learned when and why. There are innumerable operators in the world, but very few surgeons. There is a difference between operators and surgeons. They know only, so for a surgeon, decision and dissection are important. For an operator, only dissection is important for that. So I needed the hour to convert the operators to surgeons, and that's important. And as a teacher for last 38 years, it's my feeling that it takes 5 years to know and do the surgery, how to do the surgery. But it takes 25 years to know where not to do the surgery. That is important. And it is true that every surgery is easy. Every surgery is difficult. It is the surgeon who makes the surgery easy or difficult. And that's why observe, associate with a good surgeon. Don't observe, associate with a bad surgeon. Ultimately your adaptation will be the same procedure as per the mentor. So the future is the era of organ preservation. Save the uterus concept. Minimal invasive, non-invasive techniques has to be adopted. As I said, laparoscopy is a minimal invasive. Vaginal is a non-invasive. Laparoscopy is a keyhole surgery. Vaginal is a no-hole surgery. And alternative hysterectomy wherever feasible, focusing on medical management, focus on conservative surgical management is the rule. Simplifying, every technique should be simplified. You don't want to make it complex. Telesurgery and advanced robotics have come out. Nanotechnology was there, but I'm waiting for this MAH, mantra, enchanting divine rhyme and uterus venesis, mantra assisted hysterectomy. Power assisted hysterectomy. I was just having a meeting with the biomedical engineers of Johnson and discussing what are the new things which have come out in the laparoscopy. Then I suggested one thing. I want a power source. I know that you have a bipolar, you can just put it inside the uterus, removing the submucous mamma by bipolar evaporation technique. Same thing you can do it. You find out a gadget where you increase the power. I will use the 5mm telescope and one port only 3mm with a high frequency needle touching 32-week size uterus, touch the fundus only and the power generated. And after a few minutes, 5-10 minutes, the whole 32 weeks uterus will be shriveled into a peanut size. No dissection, nothing, no suturing, nothing will be required for that. I wanted, so that should be there. Or in the era of computer and technology, chip assisted hysterectomy. You apply a chip, uterus will be out. That could be there. So gynecology in new form will come and gynecologist in new shape will come. No more the same gynecologist here will be there for that. Remember one thing. This is a usual habit. Small minds discuss people. Always they discuss people. He is bad, he is good and all that, discuss people. These are small minds. Average minds discuss events. But great minds discuss ideas. There is a need of great minds discuss ideas. Don't discuss about people. And the beginning of innovation is fantasy. You have a fantasy thought and you will find this is the beginning. And I always see O. Francis Bacon's statement. Read not to contradict and confute, not to believe and take it for granted, not to find and discourse, but to weigh and consider. Ladies and gentlemen, just one, I'm showing one particularly, this is a case of vaginal hysterectomy, about 24-week size uterus, para 2 vaginal delivery, sonography done, multiple myoma uterus, at 24 weeks. And this is the procedure, how we do it. We don't do a circular incision. We don't do a typical hydrodissection technique. We just infiltrate in the anterior position and lateral position. And these sutureless techniques of bipolar. These are all bipolar forceps, Mayer clamp of Martin. I'm using this. Now there is a lot of innovations. The power is increased. The cutting is also there along with that. It is simplified for that. But this can be done. So try with a phase-wise manner. The procedure I have tried, I have initially not jumped to this particular case. I've tried with a just normal size or bulky uterus. Then first degree dysentery was there, that is there. Then I used, goes up gradually size more of different pathology. Then complex pathology, removal of the adnexa. All these has to be done. And in the cesarean, in a previous surgery, scar and all that. The techniques should be very good. And therefore, this technology of vessel sealer has helped, particularly for more complex and more difficult cases and making it simple for that. But remember one thing, always our teachers were always telling, even abdominal hysterectomy, any hysterectomy, you have to go closer to the uterus, both anteriorly, posteriorly, laterally. Then you don't want to dissect and see the ureter and then go for that. It's not the procedure for choice. It's the benign conditions. In malignancy, that you can do it. and even in an adhesions in a posterior branch. I think you can do that, and by if you go closer to that. This is a case where the myoma screw which was being thrown up, which are not used, now we are using it more frequently. And isolation of the myoma, finding out the cleavage, putting it, and then giving a traction and removing it. So myoma is a better operation, easier surgery can be done vaginally because myomectomy can be done without any significant blood loss. More difficult is adenomyoma. More difficult is transverse diameter when it is more. I think you have to chop off and do a reduction for that. Then go slow. Don't look at the watch and do the surgery. And this is another, I find that yes, there is another myoma on the right side and close to the broad ligament area. So identify the proper place and cleavage, and with the traction and counter traction. Don't pull it much, but you have to go to the proper cleavage. That's important. Pulling is not very essential. More of traction, don't give it for that. But little traction and counter traction helps, and no vigorous traction count. But the space, if you go through the current space, you go it and detect it, I think everything will be, even big size will automatically come and deliver it, whole thing. So this is a phase wise you can go, and how a bigger tumor can be delivered it. Way back in 2007, this is a picture on that. And just go myomectomy and all that, reduce the size of the uterus and then complete the procedure. And this is how, this is the uterine. You can see the uterine and coagulate that. And you go very close to the uterus for avoiding the lateral thermal spread, even if it is possible for that. Then the third myoma is again coming, and then you go one by one, and then ultimately the uterus will come out, and the size doesn't matter. The pathology is more important for that. And this is how you complete the procedure of the vaginal hysterectomy. There are a lot of indications, lot of techniques, and the patients vary, and there are time doesn't permit me to elaborate everything. You know everything in a previous cesarean, what is the technique, in adnexal lumen, how you do it, and bigger size, bisection, and removal, there's morcellation, everything can be done with that. And if a 3 kg baby can be delivered by vaginal route, why not a 36 weeks uterus can be delivered? This is my question always with that. And that is possible. If you think you can do it. Thank you very much, ladies and gentlemen, for giving me this opportunity. It's already time. I don't want to prolong you. Thank you very much.
Thank you, sir, for a wonderful deliberation on the subject of vaginal surgery. But it was a crux of the 30 years of an experience as a teacher. What a sagacious approach to suggest all the delegates that whatever has to be decided, it has to be decided in the utmost interest of the patient. When the vaginal surgery is possible, the laparoscopic surgery has to be condemned. But when the endoscopic surgery is needed, at that time, one should always go for the best interest of the patient. So that was the kind of the sagacious advice and the teaching to all of us by the great teacher, Dr. P.C. Mahapatra. Sir, thank you very much for a wonderful talk. And with this, we are ending our today's CME. I think Dr. Hetal Patolia, if she wants to add something. Oh, you can come, very well come over here and just do the formals.
So as we come to the end of this academic feast, we would like to felicitate the chairperson for today. So I would request Dr. Jayesh to felicitate Dr. Hemant sir, please. I now invite Dr. Munjal for the vote of thanks, please.
Thank you all the faculties and delegates, and thank you Mahapatra sir for flying to Ahmedabad and choosing Ahmedabad to be the first place for in-person CME. Thank you Nagori sir for the wonderful talk. Thank you Ahmedabad sir, Kamini madam for wonderfully chairing all the sessions, and thank you Hital Patalia madam for coordinating this particular event, and MCure Pharma for all the support, technical support. It was actually very difficult to arrange for this hybrid CME. I think with this smooth execution and implementation, we would definitely like to have such hybrid CMEs so as to we can have this record and upload on the YouTube channel, because the physical CMEs are not getting recorded. So thank you so much for having this hassle-free experience. Thank you so much. And we would like to have all the dignitaries on stage for the group photo. Thank you.